Okay, so today we're going to talk of suicide of a patient. We're going to be talking about receiving care, the treatment and services in an ATC, which means around the clock care setting, or within 72 hours after discharge. So some of the topics that we're going to be discussing today is the history, a primary cause, some real life examples, some solutions, the statistics, and then facts. So when mental health became recognized, so you're going to see a bunch of dates that I put on the screen. Starting with 1843, mental health as we know it was a concept called mental hygiene. Before Sweetzer's work, discussions about mental health were often framed within the border context of diseases of the mind or insanity, right? According to the National Library of Medicine. It was first mentioned in 1843 in English literature. William Sweetser in 1843 is credited with using the term mental hygiene in his book called Mental Hygiene or an Examination of the Intellect and Passions. This marked a significant step in conceptualizing the importance of mental well-being. So next in the 1880s, there's 7 categories of mental health that are distinguished in the census. These categories were mania, melancholia, monomania, paresis, dementia, dipsomania, and epilepsy. This was a significant step in the early development of psychiatric epidemiology and of classification. These categories were not necessarily intended to be a precise diagnostic tool, but rather a way to categorize and count individuals experiencing these types of conditions. So moving on to 1908, Clifford Beers, who was the founder of the American Mental Hygiene Movement, founded Mental Health America. So his book was, he published a book called A Mind That Found Itself. Let's see. So it was published in 1908. It detailed his own experiences with mental illness and the abusive treatment he received while institutionalized. Now, the book gained significant attention and became a catalyst for a reform in the mental health system, right? So it's advocating for better treatment of the mentally ill. He is best known for his advocacy for improved mental health care, particularly after experiencing and exposing the inhumane conditions in psychiatric institutions in the early 20th century. Moving on to 1917, there was a plan for uniform health statistics across mental hospitals that had been developed. So moving on to 1946, we have the National Mental Health Act. It's signed, and then it's leading to the establishment of NIMH. I call it NIM. So the act aimed to address the growing awareness of mental health issues, particularly in the aftermath of World War II, where many veterans were struggling with mental health challenges. It authorized the Surgeon General to conduct research into the causes, the diagnosis, and treatment of psychiatric disorders and to train mental health personnel. So also in 1946, the World Health Organization, also known as WHO, is established. So it's defined health as follows. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. There you go. And a mental health association is founded in London also. That's the NAMH. That's the National Association for Mental Health. All right, so 1948, the first International Congress of Mental Health takes place. The theme of the Congress was mental health and world citizenship. This was emphasizing the importance of healthy personality development within the family and its influence in wider cultural and social patterns. We then end with the 1950s. Okay, so this is when doctors began to classify depression into endogenous and neurotic types, and drug therapies for depression begin to being developed. Okay, so now we all know or may have read about mental health and the effects long before the dates that I've mentioned previously, like back in the Greek era, or say the Viking era, or maybe even commonly known the Salem witch trials. We can go on and on about when mental health really started, but what I wanted to focus on with you guys today was when it was starting to be recognized with the dates given, just to show you how long it has taken to be fully recognized as an international crisis and how long it has taken to be classified. and talked about for that matter. I feel as if mental health has always had a bad stigma attached to it. I know when I was young and I heard anything to do with mental health, I always went straight to the crazies and the insane asylums and all the movies that I watched. So the word lobotomy also comes to mind sometimes. But today, we recognize that mental health isn't that someone is born bad or wrong. It's someone who wants to do intentional harm to themselves or others, so that there are other factors that play into the mental health and how it can be helped. And for the person to be able to live a functional and normal to them kind of life. So the mental health field has come a long way in their research and treatments in order to reach this goal of functionality.
Okay, some causes to 72 hours post-discharge can be inadequate assessment or leaving the patient without like specialist mental health support and can make them feel abandoned and neglected and then can lead them to like suicidal thoughts or initiate to suicide themselves. Some indications of underlying causes of suicide can be patient-related factors, professional-related factors, or organization-related factors. There are three main patient-related factors that can cause suicide. It's can be exacerbated mental health conditions, lack of engagement with services, and non-adherence to medication. And the professional related factors can be issues from their professions of poor practice and improper documentation, as when the patient present their issues and the health professional did not update their risk assessment or like manage the documentation properly. Another factor under this is inadequate clinical inquiries. This is where professionals did not carry out enough detailed clinical misperceptions regarding the seriousness of patients' presentation. And then also like no interprofessional communication and collaboration between one another, leading the result of the patient not having the necessary support. And then organization-related factors can include inadequate psychiatric accommodation, lack of additional support, and unsafe wards, which is like a separate room for them. This can result the patient like not adhering to the trust of observation policy.
Okay, now we're going to do real life events that happened. The first one was in 2017 at Cahuilla Delta Medical Center in Tulare County. Staff did not monitor a suicidal patient, allowing himself to stab himself in the stomach with a pen. According to the state investigation, after a doctor stitched up his wound, he was readmitted to the psychiatric ward and 3 days later stabbed himself again with a toothbrush. And then our next one is in Napa Psychiatric. That was in 2011. A patient told staff he wanted to hurt himself and jumped off a second-story balcony and died. The facility failed to adequately monitor a patient with suicidal tendencies. In 2009, at the same facility, a 30-year-old man died at the facility after hanging himself from a light fixture. Also, a 47-year-old patient died after he hanged himself from an air conditioning unit on hospital grounds, according to the coroner's report. Okay. In 2020, at Aurora Behavioral Health Care, Santa Rosa County, a suicidal patient was transferred to a local emergency room. And the worker who was with the patient did not properly monitor the patient, ultimately resulting in a self-inflicted patient death. According to the state records in the emergency department, the patient was allowed to go to the bathroom alone. Contrary to the safety recommendations, the patient died there. At another psychiatric ward in 2012, a 17-year-old patient was sent to the facility who stated she was suicidal and was let go to the bathroom where she hung herself with a shower hose since she died there and she was left unattended, the investigators determined that the facility failed to protect the patient, and they did give them an immediate jeopardy citation, and it's one of the most serious violations at a hospital. Um, they were fined $50,000. In 2018, a patient died after he smuggled in a rope without staff knowing, and he used it to hang himself.
Okay, I'm gonna talk about solution to prevent similar incidents from happening again. So we're gonna make sure the patient keep them safe, keep the patient in safe environment, or keep reduce access to highly sharp items such as scissors or knives, limit access to the means of suicide, create suicide safe room, break room, closet bars, shower rods, door handles, lock up medication, sharp and other harm instruments. Be direct. Ask them, why are you thinking about suicide? Don't be afraid to ask. Most people thinking about suicide don't mean want to die or they need someone to help them. How can we prevent? Train the staff, nurses, doctors, and staff members to recognize signs of symptoms of how to respond to the suicide attempts. Educate patients to seek help from families and friends, counseling, or other connect with church groups. Teach internal coping strategies. If you think patient might need to seriously hurt themselves or having suicidal thoughts, seek immediate psychiatric help. Provide at-risk patient with a full assessment by a mental health professional trained in effective suicide care. Be there for a patient emotionally, physically, and mentally.
Here are the latest, oh wait, sorry, let me go to the next slide. Here are the latest the statistics on suicide in the United States based on data from CDC. Overall numbers died by suicide in the US in 2023, which equates to one death every 11 minutes. Contributing factors, mental health conditions. Examples are depression, anxiety, substance use disorders, social isolation, trauma, and economic hardship, limited access to mental health care. Suicide rates increased by 37% between 2018 to 2000, then decreased by 5% between 2018 and 2020, but returned to their peak in 2022. In 2023, the highest rates was people aged 85 years and older had the highest rates. Men are nearly, and this is the demographics, men are nearly 4 times more likely to die by suicide than women, though women report more attempts. And thank you.
All right, so now we're going to be talking about the facts. So number one, incidence and risk. Recent data shows that while hospital suicides are relatively rare, psychiatric inpatients are at much greater risk compared to other patients. Their suicide rate is over 100 times higher, which highlights the need for focused prevention efforts in psychiatric units. And number two, common methods and locations. Hanging is by far the most common method, typically occurring in the bathrooms and bedrooms where patient can access points like the door handles or hinges. Understanding these patterns help us target environmental modifications. Number three, monitoring and documentation. A concerning finding is that many patients who die by suicide in hospitals were not adequately monitored or that monitoring wasn't properly documented. This gap suggests the need for stricter observation protocols and better record keeping. All right, number four, prevention strategies. Prevention requires a complex approach, modifying the environment, to eliminate hazards, training staff to identify and manage risk, implementing rigorous observation protocols, and delivering comprehensive mental health care. And to conclude, while hospital suicides are uncommon, the risk among psychiatric patients is notably high. By improving monitoring, enhancing environmental safety, and ensuring staff are well trained, hospitals can better protect their patients and save lives. Alrighty.
Okay, so discussion time. So for our first question, how should nursing staff assess the risk of suicide during each shift, and what specific signs or behaviors um, they should monitor? So first we have perform a comprehensive mental status assessment, which is a detailed evaluation of a person's emotional, psychological, and cognitive functioning. It is also used in mental health settings or when a patient shows changes in behavior, mood, or thinking. It also helps nurses and healthcare providers understand how well a person is thinking or feeling and behaving. Main components of this assessment consist of appearances, behavior, speech, mood, thought process, perception, insight, and judgment. Also, during each shift or before the shift, we can also ask directly to the patient about suicidal thoughts, such as, are you having thoughts of harming yourself, or do you have a plan to hurt yourself? And then we can also assess the severity of suicidal thoughts and behaviors using the SAD person scale. That scale evaluates suicidal risk based on factors such as sex, age, depression, prior attempts, and substance abuse. So it's basically a 10 yes or no question with 1 point for each affirmative answer, and then it's tallied at the end. And then also key signs to monitor. We have sudden mood changes, such as calmness after intense distress, verbal cues expressing hopelessness or worthlessness, increased agitation or restlessness, self-harm behaviors or talk of death, engaging in reckless or self-destructive behavior. We also have emotional cues we want to monitor, such as intense feelings of anger, guilt, or shame. We also want to monitor physical cues, unexplained injuries or self-inflicted wounds, such as cuts or bruises with our patients. And we also want to monitor withdrawal from social interactions with their family, friends, or activities. For our second question, what therapeutic interventions can be implemented to reduce suicidal ideation in a 24-hour care setting? We have cognitive behavioral therapy, or CBT. It's to address distorted thinking and develop coping strategies. It also focuses on identifying and reframing negative thought patterns and behaviors. It helps patients develop coping skills to manage suicidal thoughts and teaches problem solving and stress management techniques. Another therapeutic intervention would be medication management. We want to make sure a patient gets the right medication. We also want to practice safety contracts, develop a no harm contract, ensuring the patient agrees to notify staff if they're feeling suicidal. We also want to have frequent monitoring and activity therapy, such as art, music, or exercise. And then we have group or family therapy. Those type of therapies provides a sense of belonging and support from peers. It encourages patients to verbalize feelings and receive constructive feedback. And then it also educates families on warning signs and how to support the patient post-discharge. And then for our last discussion question, how should nursing staff handle situations where the patient expresses a desire to harm themselves or others? So we first want to stay calm and maintain a non-judgmental, supportive tone to avoid escalating the situation. We also want to use therapeutic communication and open-ended questions, such as, can you tell me more about how you're feeling right now? Or what is making you feel like harming yourself or someone? We also want to remove any objects that could be used as weapons, also develop a safety plan. With that, we can collaborate with the patient to create a plan about how to keep themselves safe during a behavior. And we always want to make sure that the patient is never left alone under any circumstances. And then we also want to identify triggers and coping strategies. We want to learn what makes the patient feel this way and teach them ways to calm down. And then we also want to implement a higher level of monitoring, such as one-on-one observation. We want to watch the patient more closely to keep them safe and contacting trust staff or support persons during crisis moments. And then we also want to involve interdisciplinary team members, such as the psychiatrist, for mental health support and medication adjustments, and social workers or counselors to develop a crisis intervention plan and arrange for follow-up care. And then also security personnel. So if the patient is aggressive or a danger to themselves or others. And then last but not least, we want to document the incident in detail. We want to record the patient's exact words when necessary and body language. And we also want to document what actions were taken, because if you did not document, then it did not happen. So that concludes our presentation. Thank you.